symposium, that is Management of Diabetic Retinopathy. I invite my co-moderator, Dr. Nitin Prabhudesai. Dr. Nitin Prabhudesai is a very senior consultant ophthalmologist at Pune. He's a very well-known vitreoretinal surgeon and also trained at the Temple of the Eye, Shankar Nethralaya, Chennai. He studied at TN Medical College, Mumbai earlier to that. I invite Dr. Nitin Prabhudesai to kindly introduce the speakers of the next session, Dr. A. Giridhar and Dr. Arun Menon.
Ma'am, Dr. Nitin Prabhudesai has not joined yet because of his internet connectivity issues.
Okay, so I'll introduce our speaker, Dr. Giridhar. I'm fortunate to have trained and learned a lot under him. He's the founder and medical director of and a very senior vitreoretinal surgeon working at Giridhar Eye Institute. He has 3 decades of experience in treatment of retinal diseases and surgery. He has over many articles in the retinal diseases, and his areas of interest are diabetic retinopathy, age-related macular degeneration, vitreous surgery. He's also an alumni of JIPMER Pondicherry and Shankar Nethralaya, Chennai, and has participated as faculty in several national and international meetings. He's a passionate about imparting training to young ophthalmologists and now also to physicians. He has won several awards. Main amongst them are Pahawa Award and Vitreoretinal Society Award. He's also been the past president of Vitreoretinal Society India and Kerala Society of Ophthalmic Surgeons. I extend a very warm welcome to you, sir. And let's hear him speak on surgical and non-surgical approaches of diabetic retinopathy, a series of illustrative cases.
Thank you for this opportunity to participate in this wonderful symposium on diabetic retinopathy being organized during this international meet on diabetes. I'd like to thank especially Dr. Unni Krishnan and his wife Savita for giving me this opportunity, and also I should thank them for having included a full session on diabetic retinopathy, because we as a retina specialists feel this is very relevant to all diabetologists, physicians, endocrinologists, etc., all those who are involved in the primary care of patients with diabetes mellitus. My topic is surgical and non-surgical management of diabetic retinopathy, and this is the concluding talk in this session. And I will be giving a general overview as to what has been told during the last 1 hour, and also I will share with you some cases to explain as to what I'm saying. So in the management of diabetic retinopathy, I have classified into metabolic control, which I feel is very, very important. Laser photocoagulation is both for leaking microaneurysms in diabetic macular edema and also for proliferative diabetic retinopathy, wherein we treat the ischemic retina. Intravitreal injections, as you have heard in a very good talk, is a very important part of our care, especially in patients with DME, but also in certain selected situations of patients with proliferative diabetic retinopathy. I've written combinations, by which I mean that we combine laser with injections or injections with vitreous surgery. Vitreous surgery is restricted to eyes with advanced proliferative diabetic retinopathy, and it's primarily aimed at preventing the blinding complications of this devastating disease in its very late stages. I have included 3 points in a different color because this is often not spoken about, but I feel it's very important. Any center that is treating patients with diabetic retinopathy should have a small facility for low vision clinic, because visual rehabilitation is very important, and this really helps in improving near vision in many patients. And last but not the least, patient education is critical to the management, which will lead to a compliant regular follow-up over the years as far as these patients are concerned. So as far as the treatment protocols are concerned, we have two types of patients. One is non-proliferative diabetic retinopathy without diabetic macular edema, which require regular retinal examination as per recommendations. And number two is non-proliferative diabetic retinopathy with diabetic macular edema and proliferative diabetic retinopathy. These are the two sight-threatening complications of diabetic retinopathy, which requires treatment and intervention. So we need to understand that a proper evaluation is necessary for any patient with diabetic retinopathy, which of course includes a complete ocular examination. Best corrected visual acuity, I think, has to be done in every visit, because we want to know whether our patient is getting worse. Improvement may not happen, but then worsening is a critical area which we need to assess. Intraocular pressure, very important, especially in advanced eyes with advanced proliferative diabetic retinopathy, to detect early neovascular glaucoma. Fundus examination and color fundus photography, again, is very critical. I feel that any clinic which is screening patients with patients of diabetes mellitus for diabetic retinopathy should have a good facility for fundus photography, and any patient with diabetic retinopathy a photograph has to be taken and stored so that you can compare and for future examinations. OCT and fundus fluorescein angiography are two critical investigations that are necessary in patients who are having vision-threatening retinopathy to decide the type of management. Metabolic parameter evaluation is to be done at the initial visit by any ophthalmologist who is dealing with these sort of patients. And I have colored the detailed history because this is very important. Comorbidities has to be recorded. History of a cerebrovascular accident, coexisting ischemic heart disease and renal disease, all these are critical to decide the type of management. So when I come to the treatment, I've got two important areas that I will be covering. One is the diabetic macular edema and the other is the proliferative diabetic retinopathy. As far as diabetic macular edema, you should all understand that 1 in 5 patients with diabetes of more than 15 years duration, or 1 in 10 patients with diabetes, or 1 in 10 patients with diabetes of more than 15 years are likely to have diabetic macular edema. Therefore, the incidence of DME is quite high, especially in patients with diabetes of more than 10 to 15 years, and this causes some degree of visual morbidity. We should also understand that half the patients with diabetic macular edema, if left untreated, lose 2 or more lines of visual acuity over a 2-year period. This again is very important because you need to tell your patients so that they come to you for regular follow-up. Before I go into the actual treatment, I'll just show you a case as to how metabolic control is critical to the management of diabetic retinopathy and especially diabetic macular edema. This is one of our very old patients, which me and my colleagues have shared in various meetings, where this patient came with bilateral diabetic maculopathy. You can see the extensive hard X-rays in the macula. Then the patient had an initial metabolic evaluation, as I told you, that's critical in our management. And therefore, we found that patient had undetected nephropathy and also a dyslipidemia, and that we requested the patient to go to the physician. And the patient reported a couple of months later, and you can see how spontaneously there is a reversal of the retinopathy. And this is just to explain how important metabolic control is to the management of diabetic patients with retinopathy. And if any of your patients are worsening very rapidly with diabetic retinopathy in spite of intervention, please look into the metabolic factors, which may be one of the impediments for good control of diabetic retinopathy. So as far as diabetic macular edema is concerned and also PDR is concerned, I think over the years the DRCR trials have been a landmark. Various trials have been conducted, and there are landmark trials which have defined the current management of diabetic macular edema and proliferative diabetic retinopathy. And those of you who are interested may please read some of these very, very landmark trials to give you an idea as to what exactly do they convey as far as the management is concerned. Some of the key take-home messages from the DRCR net trials are: number one, patients need to come on a regular follow-up for the first 6 months. Patients may need at least 8 to 10 injections, intravitreal injections for the first year. And compliance to treatment and economic burden are two critical issues as far as developing countries are concerned in the management of such patients. So with this short introduction as far as the diabetic macular edema, I come to some cases. Now, this is the first case which I would like to show. This patient has got what we call as a sursinates. You see these hard exudates here in a ring form. These are what is known as sursinates. And within the sursinates are leaking microaneurysms. So we treat these leaking microaneurysms with laser photocoagulation, and we identify these leaking microaneurysms using fluorescein angiography. And you can see here post-treatment after a couple of 1.5 years later, there is complete regression or the disappearance of all the hard exudates, and the visual acuity also has improved over a period of time. Therefore, focal laser photocoagulation, even today, has got a critical role to play in certain specific situations in diabetic macular edema, like what we call as center sparing DME, where laser photocoagulation is still the primary modality of care. Now I move into the second group of patients where we have what we call as a center involving diabetic macular edema. If you see the OCT through the center of the macula here, you see the fluid collection. You see the fluid collection, and this is what we call as a center involving diabetic macular edema. Now these sort of patients are treated with intravitreal injections. So this patient actually, these patients are treated with intravitreal injections. So for this, I show you another example of a 55-year-old lady who presented a couple of years ago. You can see here the visual acuity in the left eye was a little reduced. The right eye was quite good. And she was pseudophakic, that she has already undergone cataract surgery in both the eyes. So in our evaluation, initially we look into the metabolic factors, which in this particular patient was recently under control. She did not have any nephropathy and her HbA1c was quite normal. And if we do the fluorescein angiography, that shows what we call as a cystoid leak. You can see a diffuse leak in the center of the macula, and that coincides with what we see in the OCT. Now what I am focusing is the left eye. So the left eye received multiple doses of intravitreal ranibizumab. So she received 3 to 4 doses of intravitreal ranibizumab, and you can see the response to the treatment. So this is before the injection, this is after the injection. You can see the reduction in the edema, and therefore with multiple injections, we reach a dry macula. So the edema has completely disappeared. At this point of time, if there are microaneurysms seen in fluorescein angiography, we give it a little focal laser photocoagulation to see the leaking microaneurysms. The concept is whether it may decrease the need for injections in future. So that's what we did. But the patients usually come back later again with a recurrence, because in all patients, the DME, it's a chronic disease, and patients, as I have told you earlier, they may need longer injections, multiple injections over a period of time. So the patient comes back with a small recurrence here. And again, you can see here the fluid has increased further with what we call as a cystoid, and she's also got a serous macular detachment. And at this point of time, since the visual acuity also dropped, and the patient is having quite a lot of the fluid in the macula, and especially she has got what we call as a serous macular detachment, the patient was shifted to intravitreal steroid injection, what we call as a dexamethasone implant, which has already been explained to you. And with that, again, there is a tremendous response. You can see here there is a reduction in the diabetic macular edema. At this point of time, we repeat the fluorescein angiography again, just to see whether still there are some leaking microaneurysms in the macula. So the patient received additional perifoveal laser photocoagulation and also a little bit of pan-retinal laser photocoagulation to the ischemic retina, because there are certain concepts that ischemic peripheral retina stimulates the formation of VEGF, and this can result in the recurrence of the diabetic macular edema. Therefore, you can see the fluorescein angiography here. What we are seeing here are the previous laser marks. She does not have much of a leaking microaneurysms at this moment of time. Therefore, no further laser is necessary. The patient has got a visual acuity of 6.9. There's a mild recurrence after a couple of months, but we follow up the patients without any injection. And finally, you can see here the macular edema has completely resolved. The reason why I did not inject when there was a little fluid again is because we are given multiple interventions. We are given intravitreal injections. We are combined with laser, and laser takes a little time for it to be effective, and therefore we need to give it a little time. And if there is very minimal fluid after these injections, and we can follow up these patients for a little time, especially the visual acuity is stable and there is a spontaneous resolution. And I have even a couple of years of follow-up as far as this patient is concerned, and the patient did not require any further injection. So as far as the inferences are concerned in the management of diabetic macular edema, anti-VEGF injections backbone. Visual improvement is an important index. OCT is necessary at every visit to guide the response to treatment. We combine with laser, basically with the hope that we may be able to reduce the need for injections. Intravitreal steroids, we use it as sometimes as a top-up or sometimes as a primary intervention. Basically, especially in certain specific situations. Metabolic control, I have emphasized already, and comorbidities have got a significant impact on treatment. So, and regular follow-up and long-term treatment is necessary with good patient education. So coming to management of proliferative diabetic retinopathy, already we have had a very good talk on pan-laser photocoagulation. And as I told you, we sometimes combine it with intravitreal anti-VEGF drugs. And finally, vitreous surgery in very specific situations, which I'll come to later. But what I would like to emphasize as far as PDR is concerned is that how silent the disease can be and how clinical evaluation, early clinical evaluation is very critical to the diagnosis, and how color photography helps us in this endeavor. So this is a patient with normal visual acuity, but if you see this fundus photograph, you can see here neovascular front here, you can see a suspicious neovascular front here, you can see a suspicious neovascular front here. And therefore, this patient has got multiple areas of retinal neovascularization. So this patient actually has got proliferative diabetic retinopathy. And if you do the fluorescein angiography, you can see multiple surface neovascularization. And he's got early disc neovascularization. Therefore, he has got actually high risk for proliferative diabetic retinopathy with normal visual acuity. And these are cases which are presented to emphasize the role for regular retinal examination of patients with diabetes mellitus, especially those with 5 to 10 years of diabetes or more. So this is another fundus photograph to show you, relatively normal looking retina, but then when you just do the fluorescein angiography of this patient, you see the significant ischemia. You just see the amount of ischemia and capillary closure here in this particular case in both the eyes, and you can see the laser photocoagulation. These sort of patients, we give aggressive laser photocoagulation to all the ischemic areas which you can see in the fluorescein angiogram, and that is critical to the management. And these are the sort of patients which can progress very fast into what we call as neovascular glaucoma, which is practically the end stage of this particular disease. So I just want to show you how you can have a featureless fundus with advanced disease in diabetes mellitus. So this is my next case, which just to show you how even in a tertiary center like ours, we can miss treatable retinopathy because of what you call defects in the process of evaluation. Now this patient, actually a 54-year-old lady, she had undergone cataract surgery in both the eyes in November. She was first seen in this hospital in June 2019. Cataract in one eye performed in November 2019. Cataract in the other eye performed in January 2020. Had normal visual acuity after cataract surgery, 6/6, very happy patient. But then you can see here 6/6. At that point of time, the junior doctor who had seen the patient, actually this was a community case. It was seen by one of our junior consultants, and she, not a retina specialist, moderate NPDR was the diagnosis in January 2020. She did not have a retina consultation. She came in February 2020. Now this time it's been written severe NPDR, and even at that time, no color photo was taken, no fluorescein angiography was done, and visual acuity remained at 6/6. Within 3 months, the patient has come with a drop in the vision in the right eye, counting fingers 2 meters. She is having a vitreous hemorrhage in the right eye. Therefore, now she has got high risk proliferative diabetic retinopathy. What does it mean? It only means that the initial diagnosis of moderate NPDR was not correct. Probably even at that stage, the patient had early PDR, and probably a color photography at that stage would have detected the treatable retinopathy. And this is the photograph I have at the time when the patient had a drop in visual acuity. You can see the extensive hemorrhages, and you can see the color of the retina, very ischemic retina. And you can see here the patient has got high-risk proliferative retinopathy with neovascularization involving the optic disc. So, but unfortunately, anyway, the patient was lost for follow-up. But what I would like to say is within a matter of 6 months, the patient has reached this stage of advanced proliferative diabetic retinopathy with a large fibrovascular proliferation in the posterior pole in the right eye with very poor vision. And the left eye has got a very, very aggressive disease with large areas of hemorrhage in the retina and this large neovascular proliferation. So in a matter of a couple of months, in a patient who's been coming to the hospital off and on, patient has gone into a very advanced stage of disease without any treatment. So this is just to emphasize how critical it is to evaluate some of these patients with diabetes mellitus for retinopathy, and therefore this particular disease should not be taken lightly. And this is an important message that I would like to convey to all physicians and diabetologists. So what are the indications for vitreous surgery? The indications, one, are vitreous hemorrhage. You can see here the patient has got a vitreous hemorrhage, and he has got a blob of hemorrhage right in the center of the retina on the macula, what we call as a preretinal hemorrhage. This is an indication for slightly early intervention of vitreous surgery. The next is diabetic retinal detachment, which can present in various ways. Now, this is a patient with diabetic retinal detachment. You can see here the retina is elevated here. It's a mound shape here. There's an elevated retina with a subretinal fluid, and you can see the neovascular proliferation here. So this neovascular proliferation probably is pulling the retina up, and as a result of that, there is a hole in the retina, and the retina gets detached like this. That is the mechanism. So these are all end-stage disease. And you see the retina that's not had any treatment. Therefore, these are treatment-naive patients coming to the clinic with advanced eye disease. It only means that they are not educated about the disease. The other important indication is a large hemorrhage right in the center of the retina. You can see the yellow colors because that is getting organized there. This again is an important indication for surgical intervention. And this is another patient to show you another form of a retinal detachment in diabetic retinopathy. And here again, you can see the patient has not had any treatment for the disease till now. Therefore, these are all young patients with diabetes, with treatment-naive disease. So this is what we want to prevent. We want to prevent these sort of blinding complications. All these patients require vitreous surgery, and many of these patients do show improvement. But then, in spite of the surgical procedure, the patient may have ambulatory vision or some element of vision, but quality vision to perform fine tasks may not be possible in these sort of situations. So I will just show you one or two cases as to explain to you what exactly is vitreous surgery. So this is a patient with a vitreous hemorrhage in the left eye. And when the patient has a vitreous hemorrhage, we do an ultrasonography of the eye because we can't see anything. We only see blood inside the eye. So just to understand the morphology or the topography of the blood, and also what is the situation or condition of the retina, we do a B-scan ultrasonography. So what you're seeing is the blob of blood here, which is already separated from the retina here. This is the underlying retina. So this is not a very complicated case for a surgical intervention, but this patient needs surgery because the blood has been there for quite some time. So if the blood remains in the eye for at least 2 to 2.5 months, and especially if the other eye is having good vision and then we wait for a little time, but if the other eye is also having very poor vision, probably nowadays we do what is known as an early intervention. We may not wait for 2 or 2.5 months, but much earlier, we may go in and remove the blood and treat the retinopathy. So what we do is what we call as a vitreous surgery. Now, this is a keyhole procedure. That is, we use either the entry to the eye is through what we call as a pars plana, and the pars plana is about 3.5 millimeter from the limbus, and we make three entries, one in the lower temporal quadrant and 2 in the upper nasal and upper temporal quadrant. So these are all 3 entries here into the eye. One, fluid enters the eye. In the other, we use what is known as a vitrectomy cutter. That is, it's something got a guillotine action, which I'll just show you. And the other is an endo-illuminator, which provides you illumination during the procedure. So as you cut and remove the blood, this clear fluid enters the eye and replaces the vitreous cavity. That is the concept of vitreous surgery. And these are all 25. This is a 25 gauge. We also have 23 gauge and 27 gauge. So the opening of the eye is very fine, and these are practically keyhole procedures, and the technology has improved significantly over the last 10 to 15 years. So I'll just show you a small video clipping. This is only to show many of you, physicians and diabetologists, as to what exactly we do in vitreous surgery. So you can see here the blood is being slowly removed. So it's got a guillotine action where you can the cutter here moves in and out. The inner shaft moves in and out, and as it moves in and out, it cuts and sucks the thing into the port, and it is removed. So you can see here, you can slowly visualize the retina here, and you can also see some blood on the surface of the retina. So you can see we just go around 360 degrees, and this is the abnormal vascular proliferation, which is responsible for the bleed, which is slowly being dissected out from the surface of the retina. So once we do that, we do what is known as the cleaning of the surface of the retina. Something like, I call it like, how you clean your, the floor in your house. This is actually this is a very passive mechanism. This is not an active mechanism, where we use what is known as a flute. That is, this has got an opening at the other end, and vacuum through a vacuum process. As the fluid comes in, the blood just enters this particular flute and disappears out of the eye. So we just slowly wipe it off. And as we are wiping it off, we can see the retina very well. So this is a simple case of a vitreous surgery for proliferative diabetic retinopathy, where we have initially removed the coagulated blood from within the vitreous cavity, and finally we are removing the blood that has clotted or spread on the surface of the retina. So this is a post-operative picture to show you the very good results you can see. But then, because this patient had a very healthy retina, the visual outcome depends on the functional capacity of the retina, the vasculature, the vascular capacity of the retina. And in this particular case, you can see here where both the eyes were operated over a period of time, the patient had reasonably good visual recovery. This is another form of a presentation where you can see this thick sheet of tissue or membrane on the surface of the retina. And when you do the OCT, you can see this is the retina, which should be, you just peaked up like that, what we call as a macular traction. So the macula, the center of the retina, has been put up by this sheet of membrane. And this is another indication for a surgical intervention. And modern vitreous surgery has got the capacity to remove all these membranes in a very atraumatic manner. So here again, we are doing removing the vitreous gel, and then we are making a small nick on the surface of that particular sheet, and slowly and gently we just lift it up, because this only has got focal attachment, and as we gently lift it up, the sheet is just slowly coming out from the surface of the retina, and finally it will be eaten up by the vitrectomy cutter. So we just eat it up with the vitrectomy cutter. And finally, at the end of surgery, we give the laser treatment. All these patients will need aggressive laser photocoagulation. We have got endo laser facilities now, so intraoperatively also we can deliver the laser to the ischemic retina. And finally, we replace the vitreous cavity with air, because that acts as a tamponade, because most of these patients are prone for some element of bleeding in the first few days, and therefore air acts as a tamponade, which slowly disappears, and the visual acuity also slowly regains. So this is a basic concept as far as the management of advanced proliferative diabetic retinopathy is concerned. Before I conclude, I would like to share with you this particular recent article that was published, this multi-center what you call data from various institutions in India, and this was coordinated by Professor Shobha Shiv Prasad in Moorfields and Rajiv Raman from Shankar Nethralaya, Chennai, where we looked at the long-term outcomes of proliferative diabetic retinopathy. This is a 10-year outcomes of proliferative diabetic retinopathy, because this is a very, very important paper, I feel. And if you see here, early eyes-receding treatment early in the disease course had significantly better visual acuity outcomes at 10 years. This is message number one. The message number two is that at 10 years, if you see BCVA of 612 or better is seen in about more than 50% of the patients. Now, that's really a very important information. Therefore, patients with proliferative diabetic retinopathy, thanks to present technology and also awareness, etc., definitely half the patients we are able to give a very good visual acuity over a period of 10 years. But what we want is a better result. And this is only possible by earlier detection. And this is possible only with support from diabetologists, physicians, and endocrinologists. Therefore, I would like to conclude by saying that let us work together to reduce blindness and visual morbidity due to diabetic retinopathy. And thank you all for this great opportunity.
This is Dr. Prabhu Desai here.
Yes, sir, we can hear you.
Okay. Now, the next talk will be by Dr. Arun Menon, and it's my pleasure to introduce Dr. Arun Menon, who is a consultant endocrinologist from Cochin, was an ex-professor in endocrinology from Amrita Institute, Cochin, and has extensively been trained in UK as well as in India. His special interests are thyroid disease and diabetes, and we are really proud that he has published an original article on progression of retinopathy. So I think it will be very relevant for him to tell us about his research in this particular presentation. Thank you, sir, and please go ahead with your presentation.
So you must have got a notification to unmute yourself.
Am I audible?
Yes, Dr. Arun.
And my
Go
slides are
ahead.
visible.
Yes, your
Okay.
slides are also visible.
Good afternoon. Thank you so much, Dr. Unikrishan and Dr. Savita, for having me on this session. I've learned a lot this morning. It's been really quality presentations from all the faculty. I hope to add my bit of it, looking at the medical management of diabetic retinopathy, and the ophthalmology referral perhaps has been covered in a lot of detail over the last couple of hours. So let's go ahead. So, I mean, a scenario that we face quite often is this, isn't it? A diabetic of 15 years, hypertension, otherwise asymptomatic, consulting any physicians regularly, not consulting any physicians regularly, which is the norm, isn't it? I mean, so many people just take their medicines, forget about screening, forget about everything just because they're feeling well. And this patient has moderate NPDR with diabetic macular edema. And the question really is, what is a plan of management that an ophthalmologist and physician as a team would do? Now, I'm not going to answer this question, but the whole point of my talk today would be to try and answer or try and devise a system, which I'm sure many of us are doing, but always the biggest problem is the collaborative work that when we do, we all are good at doing our own side of things, but many times it's that picking up that phone and raising our concern and getting that done, it's quite difficult in our system, and that sometimes becomes a big disadvantage to our patients. So what I will try and do is to talk to you about the management of retinopathy or the systemic management of retinopathy and the medical aspects of it. And I think it's important to realize that it begins with prevention and modification of systemic factors. And that has been, again, very clearly shown in all the talks earlier. The reason being that if vision is lost to macular edema or to complications of proliferative retinopathy, restoration of eyesight is very unlikely, especially if a lot of it has been lost. So time is the key. And it is important for us to understand the systemic risk factors involved. And I think that's many of the things we are very well aware of. Some of the things we are not aware of. And there are a lot of new emerging evidence around this area as well. So we need to have ways by which we can control these factors to prevent retinopathy. So it's about screening, it's about systemic management. Ocular management, Dr. Giridhar has very well covered in the previous session. So why is systemic management in retinopathy so important? That's largely because 5 to 10% of retinopathy is sight-threatening and needs referral to ophthalmologist. Of course, every patient needs a referral to ophthalmologist. That goes without saying. But what I'm saying is the immediate referral that goes to an ophthalmologist might only be 5 to 10%. However, 90 to 95% of these patients that we see in our clinic day in, day out can be managed by good systemic control. So they should have the screening. That goes without saying. The eye screening should be there for everybody, and we have said that time and again. However, it's equally important, or perhaps even more important, in patients who have who haven't got sight-threatening retinopathy to try and prevent or delay the onset of retinopathy, to reverse early retinopathy. That is what we are trying to do with that, and to delay the progression of established retinopathy. So all these aspects should continue whether they are having ophthalmic treatments or not, because we have very good evidence that continued treatment of the systemic factors and the metabolic factors are very, very important for good results or good outcome of ophthalmological procedures as well. So these are the risk factors that I'm going to touch upon. Some of them are modifiable risk factors, which are the ones that we all know about: the plasma glucose, the blood pressure, and serum lipids. I'll touch upon anemia and smoking as well. The non-modifiable, the duration of diabetes, and that is an important factor and perhaps the single most powerful factor. There are familial genetic factors that affect the retinopathy. There are other factors like the complications, nephropathy, cardiovascular disease, pregnancy as an area, medications. So there are quite a few others, and I'll have time to touch upon all these aspects. So what was the initial evidence that we had? The Wisconsin epidemiological study very clearly showed that retinopathy was related, especially in age of less than 30 years. So we are talking about type 1 diabetes. In type 1, these were the factors that were associated with severity. That is the long duration of diabetes, the high HbA1c, the high diastolic blood pressure, proteinuria, and male sex. So you can see the pattern that's emerging. So this is something which you all know. But this started way off in 1980s when we had excellent evidence from the epidemiological studies. And then if you look at the type 2 diabetes, again, for the Wisconsin study, it was classified as age less than 30 and more than 30. So there could have been a few type 1s in the more than 30, but it doesn't matter because it's quite a big study and a large proportion and a large number of patients. There again, you can see that the important systemic factors were the duration of diabetes, the age of onset of diabetes, high HbA1c, high systolic blood pressure, use of insulin. I'll touch upon that later. The presence of proteinuria. So interestingly, there have been studies from India as well, especially from the Chennai group, which have shown that very similar factors are relevant in Indians as well. So I don't think there's any difference in our population. And there have also been evidence to show that there's not much of a difference between urban and rural population, unlike many other complications of diabetes. So let's look at the duration of diabetes. This is something which we all know. It is it has been very clearly proven that the first 2 decades of diabetes, nearly all patients with type 1 diabetes would develop some retinopathy. It might be very early retinopathy, it might be just a few microaneurysms, but within 20 years, almost all type 1 patients would develop some retinopathy. In type 2, more than 60% would have developed within 20 years. So what is important here? Perhaps early diagnosis, early glycemic control or tight glycemic control, and awareness that the patients develop. That is probably because we're not going to change the duration of diabetes, but of course we can change if we were to prevent type 2 diabetes for a period of time. But type 1, perhaps we can't make much of a change. But it's important that we realize that so that we can be much more watchful. There is data also from India. Again, you can see here that if less than 5 years of diabetes versus more than 15 years of diabetes, see the prevalence difference, less than 15 versus 41%. So it's clear that duration of diabetes is one of the single most important factor that affects this. The second, perhaps equally important, something which we can change, which we can modify, is the glycemic control. And there again, the evidence from India would show you this, that if your HbA1c is less than 6.9, about 8.1%, versus if it's more than 10, about 31%. So clearly, a poor glycemic control has got a big impact on retinopathy. But the landmark trials, which showed us clearly how we need to manage patients with retinopathy, were the 2 studies that you all know about, but have to keep on mentioning those 2 because those are the studies on which our current management of diabetes and modern management of diabetes control is based on. And this is the DCCT and the UKPDS. The DCCT was on type 1 patients. And as you can see here, this was on the primary prevention cohort, which means people who didn't have retinopathy. And this is on the secondary prevention, which is people who had some amount of retinopathy before they got into this trial. And the conventional versus intensive therapy with insulin, because this is type 1 patients, you can see that there was a significant improvement in intensively treated group. So whether it is development of retinopathy or whether it's worsening of retinopathy, both can be improved over a span of 9 years, this study was. Both can be reduced if you have intensive treatment with insulin in type 1. Take the case of type 2 diabetes, and this is UKPDS study. There again, you can see this is a HbA1c of less than 6, 8, and 9. And you can see the difference in the event rate. So if the HbA1c is higher, there is a clear increase in the event rate. So type 2, it is again very well proven. A very good study and an excellent study to back up those two were the steno trial. Again, all of you know about this one. And the steno retinopathy, as you know, the steno was an intensive treatment trial with not just glycemic control, but also with all the risk factor modifications, ACE inhibitors, statins, aspirin, everything together. And you can see here that there was a significant difference in the retinopathy progression. So it is clear that glycemic control is extremely important, and that is perhaps the best way we have, especially early diabetes control and long-term control is the best one we have. The pharmacological therapy perhaps doesn't matter, but it is a risk factor control that is important. Now, add to that was the evidence that came from the follow-up of these two studies, the DCCT and the UKPDS. And that is something, again, which we talk about quite often. It is the concept of metabolic memory and the legacy effect, which means if you have intensive control for about 10 years in the beginning, even if your control was to go off, which is what happened in this UKPDS group after the study, so their control became equal to that of the conventional group. However, the benefits in terms of microvascular reduction, especially retinopathy, continued. So if you have 10 years of good control, there seems to be some sort of metabolic memory that the body has, so that you will continue to have the benefits of it, even if your control was to get worse. So that was clear in UKPDS. The same thing, interestingly, was shown in the EDIC study. EDIC was a follow-up of DCCT trial. You can see here the DCCT trial where the intensive and the conventional group, and after the study, their HbA1cs became same. However, you can see that the benefits in terms of reduction in retinopathy development as well as progression continued despite their control getting worse. So that is the concept of metabolic memory or the legacy effect. Now, is HbA1c the only one? Perhaps not. I think this is an interesting study, and there's quite a lot of work that's going on around glycemic variability and diabetic retinopathy, which probably is a missing link. We don't know at this stage. But what you need to understand is that behind every HbA1c, there is that variability in blood sugar. So you could get an HbA1c with a variability of blood sugars like this, or this, or this. So that it might be perfect all the time, or it might be going up and down. And we now have excellent tools in terms of CGMS, which are very easy to use and which will give you a excellent pattern or excellent profile of how the blood sugars are. There was a study that we have done, which is still unpublished, and it's so I don't have all the data on this, but we looked at the severity of diabetic retinopathy and glycemic variability with a CGMS, and it was just been presented in some of the ophthalmology meetings, I understand, by Gopal's group. And you can see here that there is very clear evidence that as the severity increases, the variation or the glycemic variability increases. You look at the standard deviation or the coefficient of variation, both were increased. Now, that doesn't mean that it is a causative factor. It probably is an association. However, this is an area that we will see more and more evidence, and we could put this into clinical practice in terms of getting better control for these patients and reduce the retinopathy. So good glycemic control is important. HbA1c is perhaps the best marker we have now, and less than 7 is what we need to look at. Now, remember that when you're tightening the glycemic control, it may initially produce transient worsening of retinopathy. I'll come to that later. But in those sort of scenarios, when you're going for very tight control, you need to monitor the retinopathy. If patients have retinopathy or has previously not been screened or recently not been screened, then you should certainly think about looking at the eyes as well. What about hypertension? Hypertension, we know, can cause hypertensive retinopathy, but that's not the issue here. In diabetic retinopathy, that can be made worse by hypertension because of a variety of mechanisms. And there are very good evidence, again, from UKPDS and Euclid studies about this. So if you take UKPDS and look at it, it is clear that if you were to control both blood sugars as well as blood pressure, you can reduce the progression of retinopathy significantly. So it is just not the sugars alone that you should look at. Blood pressure is perhaps equally important or even more important. See the kind of benefits you can get with blood pressure control. So, but one thing to note in terms of blood pressure control is, although with blood sugar control, there is a legacy effect or a metabolic memory, with blood pressure, there was no metabolic memory shown in these studies, which means you have to continue to control the blood pressure. If you lose that blood pressure control, then actually your complications will continue to increase. So unfortunately, blood pressure control is something which you have to continue to have. Is any agent better than the other? There was the direct trial with candesartan, which disappointingly didn't show any evidence. So at this point, any antihypertensive is fine as long as you're getting the blood pressure under control. What about dyslipidemia? Again, another area where there has been a lot of studies looking at association between dyslipidemia and the hard exudates. And there is very clear evidence that dyslipidemia will increase hard exudates. However, treatment with lipid-lowering agents have not given us much of joy in terms of reducing the retinopathy. The only trial which did show some evidence in terms of reduction was the one with fenofibrate, the field study. So perhaps the only drug that can claim that they can reduce retinopathy is the fenofibrate. However, there was no clear relation between serum lipids and progression of DR in this. So whether it's an independent effect of fenofibrate, we are not sure. Another factor that you need to counter in diabetic retinopathy is anemia. And anemia can lead to progression of DR by aggravating hypoxia in the retina. And there have been very clear studies again showing that anemia can worsen retinopathy. And interestingly, treatment with erythropoietin in patients in diabetic nephropathy patients have shown beneficial effect in diabetic macular edema. So that's an interesting area. And I think anemia is certainly something which we should look for. I'm sure many of the retinal specialists look at these aspects very closely. But as a physician itself, I think we should be aware of this and we should check this so that the patient benefits. What about diabetic nephropathy? Another important aspect. Again, we have seen that patients with nephropathy can have worsening of, more worsening of retinopathy. Those two always come together, occur together. PDR is increased in nephropathy. Not only in nephropathy, if you look at microalbuminuria versus macroalbuminuria, there is a increased risk compared to, and this is from a local study from a South Indian study, which showed that the macro, the risk is about 6 times compared to micro. So that is another factor we need to look at. Even cardiovascular disease, I'm not going to go too much into it, even cardiovascular disease has been shown to cause increased diabetic retinopathy. So as far as we are concerned, if patients are having a cardiac event or active cardiac disease, let's not forget the retinopathy side. It might have been stable before, but it might mean that we need to screen them earlier. Pregnancy is an area which is quite specialized. Many times, many metabolic changes happen during pregnancy. It is very clear that the diabetic retinopathy can worsen during pregnancy, especially in the start of the second trimester. And there's been studies very clearly showing that. There have been the best thing would be the screening at each trimester and making sure that that retinopathy is taken care of. So what is recommended is every 3 months. So first trimester and then every 3 months, or as the ophthalmologists decide. Now, this is a work that I had done during my time in research in retinopathy. And it is clear that the transient worsening of retinopathy in pregnancy, in type 1 at least, is not having any long-term effects. So it seems to be a transient one. If you deal with that appropriately, the long-term visual prognosis is not worsened if you actually treat them properly. That seems to be what came out of. So this is a long-term study we looked at, and what was clear was that it is not associated with postpartum worsening of retinopathy. So the long-term prognosis is not bad. So pregnancy is not a risk for, it is a risk for transient worsening of retinopathy. If you deal with that well, then the long-term visual risk is not there. And I think it's an important point to note. What about the medications for diabetes and retinopathy worsening? I think it's something which Unni had touched upon in some of the discussions earlier. Here, it was very clear from the DCCT trial that there is early worsening when you actually tighten the glycemic control. And this is the question that we need to answer. And this is a controversial area. There are two schools of thought in this. So there are many who believe that insulin per se would worsen retinopathy in the short term. Whether that is due to the rapid improvement in glucose control, in fact, many people believe that it is a rapid improvement in glycemic control that is causing this worsening, because insulin, as you know, is a powerful agent and it causes significant drop in HbA1c or sugars, and that usually can actually worsen it. So it's a paradox of initial worsening of retinopathy and a decrease in long-term retinopathy with insulin. However, there's also a group that thinks that there is a synergistic action there. Perhaps the high dose of exogenous insulin with the VEGF expressed by ischemic retina might trigger vascular proliferation. So it's an area which there have been evidence for and against. And I think we have to be, our approach has to be that when we are starting somebody on insulin, if they already have retinopathy, they should be closely followed. Make sure that they're on stable. So I think perhaps it's difficult to control that blood sugars and say that, oh, I don't want it to drop too quickly. That sometimes may not be possible for us. But as long as we are looking at retinopathy on a very close interval, making sure that the retinopathy is stable, then that is fine. So this was another study that I had done. This is now nearly 15 years ago, so a long time ago. But again, what we looked at was a long-term progression of retinopathy after initiation of insulin therapy. So what it showed was that the initial worsening seems to be a transient phenomenon. So if you actually look at these patients over 3 years or longer, it looks as if there is not much of worsening at all after that. So the initial worsening is there with insulin therapy, but you can't say that insulin will continue to worsen retinopathy. In fact, if your glycemic control improves with insulin, your retinopathy will reduce, and that way insulin is perhaps the right treatment. And I think there is really no concerns in the long term when you're using insulin therapy. What about glitazones? Something which we all very well know about. The glitazones, I think this was mentioned by Dr. Sugandhi as well, I think in one of the discussions. The thiazolidinediones can worsen DME, the diabetic macular edema, both in short and long term. So it is something which you should be aware of. The semaglutide in the SUSTAIN 6 trial. So this is an area that is still emerging. The drug is not still out. We're still waiting for it to come out this year or next year. And there has been, at least in SUSTAIN 6 trial, there has been an increase in retinopathy complications with semaglutide. Again, the question is it because of rapid improvement in glycemic control? Because these are very powerful agents. It could be, or there could be other agents. So it is something which we need to be aware of. Hydroxychloroquine-induced retinopathy. This is not diabetic retinopathy per se, but Dr. Unni did mention the fact that it is now licensed for treatment for diabetes for some time. We have to be very careful in these patients. There are a lot of risk factors in this that we should be aware of. If we are aware of this, we can be very careful. So any patient on hydroxychloroquine, the best would be to have a baseline eye checkup and then have yearly checkup after that. What is the role of aspirin? There is really doesn't seem to be any beneficial effects with aspirin. However, it doesn't appear to increase bleeding either. So if it is indicated for other reasons, aspirin can be given. The other treatment, the anti-VEGF treatment and the cardiovasculars, this is another thing that we are all concerned of. The risk is small. This is because with anti-VEGF, even local treatment, there could be an increase in the blood levels of VEGF, although albeit small. So the risk is to the tune of less than 1% of cardiac risk. But those patients who are at high risk of stroke, like atrial fibrillation patients, you have to be very careful. The blood pressure control is extremely important. And these aspects need to be looked at by the physician as well as ophthalmologists before we send the patients. So ophthalmology referral criteria, I think it's something which you all know very well. I'll just quickly say that with type 1, what you would do is screening within 3 to 5 years after diagnosis, fine. I would personally say and in this day and age, we can always get a screening at the start itself. Why not? Sometimes, depending on the type of whether it's type 1 or maybe other types, you could have other ocular problems as well. So have a screening first, and then yearly screening is perhaps the best. With type 2, definitely 100% you need a retinal screening first step itself. In pregnancy, we have talked about. So annual screening is the way to go. What about once they develop different grades of retinopathy? I think this is something in the realm of ophthalmologists. They will decide. It's not up to the physicians to decide this. And there are different criteria that have been given. However, I think the follow-up pattern might differ between different ophthalmologists. Different cases, they might be more comfortable. In certain cases, there is that sixth sense that ophthalmologists will have, and they will decide how to follow it up. But what I'm trying to say is, if no retinopathy, annual is fine. But as the retinopathy progresses, you will need to have more frequent screening, if not treatment, but at least screening. So we have come to the end of this talk. I think what is clear is that the medical management of diabetic retinopathy is extremely important. All these factors are important. These are the kind of levels that we need to achieve in these patients: less than 7 HbA1c, less than 130/80 blood pressure, less than 200 cholesterol, less than 150 triglyceride. These are the essential questions I feel you should ask in any patient who comes to you, especially who has some eye disease or is going for some treatment or having some treatment. So what would be your advice to in terms of screening? You would tell all patients that they should have annual screening. I don't think we should compromise on that. Then we did talk about the ophthalmoscopy and screening and all that. Of course, all that is very, very important. History-wise, the duration of diabetes, you really need to understand that, because then you can prognosticate. The poor glycemic control, you need to have an understanding of current and previous, HbA1c, the other risk factors, the medications, and bariatric surgery. So I've said that many of these patients will remain under the physicians, or in fact, they will remain under physicians for management of all the complications. It's easy to miss out on the ophthalmology side. We shouldn't do that, because that could be the difference between vision and blindness in these patients. So a multifactorial approach is what we require, and that is what we should aim to do. Thank you.
Thank you, Dr. Menon, for your excellent presentation. I think you really covered all the points we ophthalmologists need to know when dealing with patients with diabetic retinopathy. However, as Dr. Munna has put just now, we interestingly have sometimes patients who are not under good glycemic control, have diabetes for a long time, and they don't have any diabetic retinopathy. What's your explanation for this, please?
Yeah, I don't think we have an explanation for this as a single explanation. So I think this is why, isn't it, we are looking at different factors. I think whenever we don't have a clear explanation, we always start with genetics. So I think there is certainly, this familial clustering has been one of the factors that have been studied, and there is a lot of work going on in that area. So that is certainly one of the areas, genetics, because that's something we haven't understood very well. There are a lot of studies, again, even from India, on the genetic side of things. And I'm sure that some of those seminars here might have been involved in this as well. The other thing is, in terms of glycemic control, I was talking about the CGMS and the glycemic variability and all those factors. Those are certainly factors. So there is a tendency, and as you're absolutely right, there are people with HbA1c of 10 who don't get any complications and who go on. Why is that? Don't know. We don't know what protects these people from retinopathy or other microvascular complications. But we know for a fact that once they fall off that perch, then it's a very rapid downhill course. So from our side, as physicians, with the knowledge we have, I think we need to continue to do the boring work. It is boring, but at least continue to do that boring work for our patients.
Regarding this tight control, if the patient presents to you with, say, something like a sugar of 350 in the beginning, So how fast would you like to get that control down? Like in basic, do you have any time frame for that?
Yeah, personally, I'm not very concerned because unless they have very active retinopathy, or whether they are on active treatment for the retinopathy, say suppose somebody is undergoing laser treatment, even then, I think all ophthalmologists would say that we would like a good control. So that's give us that. We will deal with the retinal side of things, because I think in the short term, unless it's a very complicated case, many of the times with frequent follow-up, you guys will be able to give them the right treatment, laser whenever required, whatever treatment is required, and get it. So it's macular edema that can sometimes be very tricky. But again, we don't have very clear evidence to say that if we were to go slow in these patients, we would actually do them any good. Because so I think we have to do a bit, but with I think caution is the word to be used there, and very regular follow-up.
Also, we have issues with patients who are on regular for nephropathy. They are on dialysis, and they also have macular edema. So, we sometimes have to keep giving them anti-VEGFs, and many times when they are undergoing dialysis, the BP also shoots up. So, what do we do with these patients?
Again, I think that's probably why I said initially it's picking up the phone and talking to your colleague, because many of these cases are extremely tough, and we all deal with this day in, day out, especially if you work in a big hospital. But I think we can't take a step back. We know these are, especially say a dialysis patient, for example, they're going to have fluctuations in blood pressure, their retinopathy. So I think it is treating both at the optimum way with whatever. It's very close follow-up and aggressive treatment of both aspects. So one needs to know what the other one is doing. I think that is where the trick is.
Savita, any more questions with you?
Thank you for that. We are running out of time, but maybe last comments from Dr. Giridhar before we close. Thank you for being here, sir, and wonderful lecture as usual.
No, I think it was a very good session. A lot of interesting, important information. I think it was a very comprehensive session on diabetic retinopathy. And I have nothing much to say. I think a lot has been discussed and a lot has been said. One or two points which I thought would be of use is, number one is in any major hospital treating diabetes, like for example, your center, I think a good imaging facility, especially a good camera, will be very useful. I mean, it's a very good investment, and I think that's very necessary. So I feel that the infrastructure should be titrated according to the number of patients we see, and because there is no purpose in having diabetic retinopathy screening camps. I don't think that is able to identify treatable retinopathy. Treatable retinopathy has to be identified from centers dealing with large patients with diabetes. The second point, last point before we conclude is, I think Arun spoke extremely well. One point which I would like to add is, any infection, what we have seen is infections worsen retinopathy. I mean, that is urinary infection, diabetic foot. All these things act as a trigger factor for worsening of retinopathy. And these are also situations where I think a close monitoring of the retinopathy is necessary.
Absolutely, sir. I mean, the condition we see quite often is a diabetic foot, and the worsening. It's been something which we have noticed quite a bit. Diabetic foot infections and, as you said, urinary infections as well. But yeah, point well taken. Absolutely.
So
thank you, everybody.
I think you're getting late.
Thank you, everybody. It was wonderful listening to all of